Welcome to a new episode of Médecine in 3 minutes. As usual, we go straight to the point. The subject is briefly made clear and often illustrated. The topic today is about Placenta Previa. This is how we will approach the presentation. Late pregnancy bleeding, the bleeding of Placenta Previa bleeding, prevalence, risk factor, mechanism of placenta migration, Placenta Previa type, physiopathology of bleeding, management, and then Placenta Previa versus Abruptio Placenta. Regarding late pregnancy bleeding, there are 4 chapters: Abruption Placenta, Placenta Previa, Vasa Previa, and uterine rupture. If you want to tackle this question of Placenta Previa briefly, one could say it's a multigravida that wake up in a pool of blood and no pain. The fetus presentation is transverse line. 3 characteristic points: multigravida woman, pool of blood, no pain, presentation is transverse. What is the prevalence of Placenta Previa? At 16 weeks, it's about 20%. At 40 weeks, it's only 0.5%. Why the difference? Because the trophotropism. Tropho means placenta and tropism means movement. The essential characteristic of Placenta Previa is about the low uterine segment. Here is a normal insertion of placenta. This is the cervix. The most important issue in this chapter is the low uterine segment. How the migration of placenta occurs. Placenta migration occurs because the atrophy starts here, and then it moves here, and then it goes there. Here is the low uterine segment, and here is the cervix, and atrophy, it starts from this low uterine segment, and the placenta moves. Placenta Previa, we repeat, it's late trimester bleeding. It's low segment placenta implant. One characteristic of the bleeding, no pain. Placenta Previa, painless bleeding, 3rd trimester. Type of Placenta Previa are 3. The marginal one, then partial, and then central. Here is the normal placental implantation. It is not in the lower uterine segment. The lower uterine segment is free in normal placenta implantation. From the marginal, because Placenta Previa is close to cervix os. And this marginal, there is maternal blood. When it's partial, it's almost over the cervix. And also with maternal blood. total, partial, marginal. Pathophysiology of bleeding. Avulsion of the anchoric villi, stretching of the lower uterine segment. Why we don't have bleeding in the first trimester? Because lower uterine segment has not formed yet. It is formed until the second trimester. Is there any risk factor? The answer is yes. First, previous placenta previa. Second, multiple gestation. And the third one, artificial reproductive technique. This is increase the risk of placenta previa by 5 times. Implant in the lower segment and increase the risk. Artificial reproductive technique increase the risk of placenta previa. Why? Normally, fertilization happens in the fallopian tube. The zygote descends to the uterine cavity from above. In vitro fertilization, embryo is taken from below. The embryo is implanted in the low segment. This is increase the risk of placenta previa. Nowadays, we try to implant the embryo as high as possible to minimize the insertion in the lower segment. Management. If maternal and fetal jeopardy, emergency cesarean. If preterm stab for mom and fetus, conservative in hospital. If marginal placenta over 2 cm from os, vaginal delivery. Term stable mom and fetus, schedule cesarean. Preterm stable mom and fetus, conservative in hospital. If the cervix and placenta are more than 2 cm apart, lower plantation may have vaginal delivery. This is the placenta, this is the cervix. If it is over 2 cm, we can try the vaginal delivery. Total central placenta previa, almost over the cervix. This one will not go away. This one for sure a cesarean delivery. Maternal blood. Let's review. Placenta previa, 0.5% of delivery at term. Mechanism, avulsion of anchoring villi of the implantation placenta with stretching of the lower uterine segment. Risk factor, multiple gestation, multiparity, previous placenta previa, and advanced maternal age. Type 3, complete, cover internal cervical os, partial, part over internal cervical os, and low-lying, close to the internal cervical os. How to differentiate from Abruptio Placenta? Frequency is 1% of delivery. Mechanism is hemorrhage into decidual basal behind normally implanted placenta. Risk factors are hypertension, cocaine use, previous abruption, and trauma. Treat type, overt, external vaginal bleeding, concealed bleeding hemicene, and retroplacental and only internal. Abruptio placenta, painful bleeding, third trimester. Thank you for watching this episode of Medicine in 3 minutes. Would you like to click the button like and subscribe? Your comments are very welcome. Thank you.